MRCP, we found that there was something happening there at the genu, where in the head of the pancreas, in the neck of the pancreas, the duct was not proper, and beyond the genu, the duct in the body and tail was mildly dilated. So I would like you to see now this MRCP picture. So somewhere over here in the genu, you see a very complex anatomy, pathomorphology of the duct, something happening here, some obstruction here. So our aim is now to first perform an ERCP, try to go through the major papilla, see what we find. A little bit of duct is seen in the head with some dilated side branches. Now this is appearing a little funny picture, and I'm not very sure because I'm not getting the duct in the body and the tail over here.
We can see that nothing is going across the genu here.
Nothing is going beyond the genu, exactly. So either there is some tight stricture there or there's something else going on. So let me pass in a guide wire and see where the guide wire is going inside. I prefer to use a angle tape Terumo guide wire for the pancreas, especially for the initial cannulation, so that we have the highest chance that we can negotiate across if there is any obstruction. So we have entered inside the pancreatic duct now. I'm passing the sphincterotome a bit inside, and I'm seeing what's happening there. This is a very
you can
complex
nicely
anatomy.
see how helpful this angle tip wire is here. So you avoid the side branches here.
Yeah, exactly. So there's something happening here. It's going somewhere in the side branches, which are dilated, saccular and dilated. I'm sucking this fluid. Now I'm going to push the scope inside, push the scope inside, push the scope inside. And here you can see that there is a little bit ampulla looking structure. And now for cannulating the minor papilla, I'm using a special minor papilla cannula, tapered metallic tip made in Germany by Hans Christian Grosse from Hamburg. You can see how this is. So what I'm going to do is gently go here, gently go here, gently go here, gently elevate it. Okay, now let me inject and see what are we getting.
You make it look too
easy.
Now we can see the duct.
Wow. So that means this was, so this complex anatomy was basically, it looks like a divisum to me. So what we were filling through the major papilla were just dilated side branches. So I think this is the cause of his recurrent episodes of acute pancreatitis. So now what I do is, by passing this cannula, I'm going to move this cannula in and out a bit, so as to dilate this orifice a bit. So over the same wire, the Terumo wire, I'm going to keep the wire in, gently pull the sphincterotome back, hold the shaft of my scope.
We have been talking a lot about electrosurgical settings. So what type of current are you using here?
It's the normal endocut Q, which we use for normal sphincterotomy. Unbend. So I'm pulling it back. Now in a minor papilla sphincterotomy, we need to remember that we have to cut the sphincter properly, the ampulla completely, because we should not do a hesitant cut. Otherwise, many times what happens is this, you can see what's coming out.
Yeah.
Very nice.
What is coming out is pancreatic juice along with this pancreatic stone protein plugs. What I want to do is, you see here in these small protein plugs, if you just inflate a balloon, those protein plugs go by the side of the balloon, and you can't actually push the plugs out. So with a basket, they tend to come in the basket, and see what I'm doing now. I'm keeping the flower, the basket wires open at the ampulla, and now I'm sucking. So the basket keeps the ampulla open, and then at the same time, if I suck, the fluid along with the protein plugs, it starts flowing out. So I think this is good enough for now that we have done a pancreatic sphincterotomy of the minor papilla. And I'm just going to place a single pigtail pancreatic stent, and this therapy should be over.